Ma'am, we are live now.
Okay.
Yes, ma'am. Good evening to all the delegates present over here. On the behalf of Corona Remedies, I, Piyush Shukla, welcome you all for the COR Connect live webinar series by Dr. Sunita Tandulwadkar. After completing 8 successful webinars series today, we are here on the 9th webinar on preterm labor dilemmas and solutions. So before moving forward, as being the rituals, let's start with the lamp lighting ceremony. Thank you. I'm 1000% sure that everyone who is joining this webinar right now would be really feeling proud that we have a speaker today with us. Let me introduce her with you all. She's head of the department and chief IVF and Endoscopy Center, Ruby Hall Clinic, Pune. She's also advisor and consultant to Dr. D.Y. Patil, IVF and Endoscopy Center, Pune. She's founder and medical director of Solo Clinic IVF. She's also founder and medical director of Solo Clinic Stem Cells. She has been president to POGS in the tenure of 2021-2022. She's chairperson to and founder honorary secretary to ISAR. She's senior vice president in ISAR. She has been president to IAGE 2019 to 2020. Vice president.
Okay, let's start to the academics.
Ma'am, please let me tell everyone that having a lot of extraordinary achievements, she also has one very remarkable achievement, which I myself felt very proud after reading it. She has the extraordinary achievement of India's first stem cell body and world's first at the age of 45, 16th April 2018.
Baby.
So, yeah, a cell baby. So before I hand over the session to Dr. Sunita Tandulwadkar, ma'am, very welcome, and please proceed.
Thank you. Thank you, dear. So good evening. First of all, thanks to Corona. For last 8 months on second Monday, 7:30 p.m. we are coming. We take one obstetric or a gynec topic and we just work on that topic. And for 45 minutes, we discuss one topic in depth. Any questions you can, if there is a chat box, you can always add on to them. Namaste, Vanakam, Sri Sat Sri Kal, Namaskara, because we have a global these things. Good evening, everybody. And thank you for being there. All truths are easy to understand once they are discovered. The point is, we need to discover them. Dear friends, today I'm taking you to the journey of preterm labor. It's like in 45 minutes, what are the recent updates or recent management which are given in all our international or national guidelines? I discuss and I talk to you. Why we are taking this subject of preterm labor? Because if you see, premature birth kills one baby every 30 seconds. It's a shocking percentage and statistics what we got. 5 countries with the greatest number of preterm: US, Brazil, India, China, and I can't even read the third one. The 15 million babies are born too soon every year. These are the world statistics. I'll be telling you the statistics from WHO. Now, WHO in 2010 has said these are the 10 countries. Of course, Indonesia, I think it was Indonesia written there. India was the topmost in the list. And in 2018, WHO revised, and it is shocking to know that Asian and sub-Saharan African countries together count for 81% of preterm birth globally. This is too huge amount. We all know that preterm births are the single largest contributor to perinatal mortality. And the most common causes of this thing is respiratory distress, the sepsis, intraventricular hemorrhage, or necrotizing enterocolitis, which will take the life of a baby. So there are different diagnostic criteria, and that may be the reason the statistics is varied. If you see WHO, they call less than 37 weeks preterm, moderate to late preterm 32 to 37 weeks, very preterm 28 to 32 weeks, and extremely preterm 28 weeks. Now, if you see ACOG, they guide less than 37 weeks preterm, 34 to 36 weeks late preterm, and below 34 weeks, all are early preterm labor. Some may label it with the birth weight. Low birth weight, less than 2.5 kg, very low birth weight, less than 1.5, and extremely low birth weight, 1 kg, to label this as a preterm. Now, accurate identification of a patient is mandatory because that allows us the appropriate application for intervention, such as antenatal corticosteroids, prophylaxis of antibiotic, magnesium sulfate for a neuroprotection if less than 32 weeks, and maternal transfer to a facility with appropriate or tertiary center. Now, just as important, it is the accurate identification of a patient. If you really see 50% of the patients with suspected preterm labor who subsequently give birth at term without any tocolytic. So sometimes it unnecessarily adds to the cost of the patient for the antenatal care by just misdiagnosing it as a preterm labor. So if we talk about the preterm labor, it's very important that all of us should know what are the risk factors, so that this particular category of patients, my last 2 slides include that, we should try and work, how do we prevent these risk factors? Now, though 50% or more than 50% is idiopathic, reproductive tract anomalies, maternal diabetes, intrauterine infections, IUGR, preeclampsia, maternal hypertension, environmental factor, and multipetal pregnancy. All these are the more or less the positive factors for it. And if you see below 23 weeks, if these are there, genetic susceptibility should be our highest. While the causes for giving preterm, chorioamnionitis, IUGR, maternal hypertension, and gestational diabetes were found to be more. And why this is important? The development of antenatal period, if you see why mortality we talk about, between 23-6, though organogenesis happens in first trimester, between 23 to 36 weeks, we have bone mineralization, we get maturation of a HPO axis, we get nephrogenesis, we get saccular development, especially canaliculaar development happen between 24 to 26 weeks of gestation. So if anyone delivering before 26 weeks, definitely they will have all pathological lung signs. Vascular development and cardiomyocyte proliferation, all that happen in this period, and that is why it is very important. While 37 weeks to 40 weeks, it is just the baby's weight gain which happens, we all know that. Pathogenesis of a preterm labor, these are the causative factors. So we saw the risk factors, and the causative factors are again more or less, again, idiopathic goes more, but the stress, infections, we know that overdistension of uterus and any breakdown in maternal-fetal tolerance can cause that. So the pathophysiology of preterm labor involves 4 primary pathogenesis. 1, stress-induced premature activation of maternal or fetal hypothalamo-pituitary adrenal axis. Second, exaggerated inflammatory response, infection or altered genital tract microbiomes. Third, decidual hemorrhage. Fourth, pathological uterine distension. So it may be polyhydramnios, massive, or it may be the multiple gestation. If you see the clinical findings, obviously those clinical findings that define true labor are the same whether the labor occurs preterm or at term. But sometimes patient may come with menstrual-like cramps, irregular contractions, low backache, pressure sensation in the vagina or pelvis, vaginal discharge of a mucus or a blood stain, spotting, or maybe a slight bleeding. Uterine contraction are the sine qua non of labor, but mild irregular contractions are normal finding at all stages of pregnancy. Thereby, it adds the challenges in distinguishing true labor from this Braxton Hicks contraction. Only 13% of the patient presenting less than 34 weeks of gestation who met the explicit contraction criteria of preterm labor give birth within 1 week. It means in 87% of the patient, you can prolong. Either it was misdiagnosed or you can help them. A short or dilated cervix may be the first clinical manifestation of an impending preterm labor, which is triggered by subclinical infections. Now, diagnostic evaluation. How do I diagnose? First is history, and then general examination, per abdominal examination, per speculum examination, per vaginal examination, sonography, and lab evaluation. In history, just find out whether there are risk factors apart from diabetes and hypertension, previous history of preterm labor, previous history of incompetent or suggesting findings, painless deliveries, previous history of preterm labor itself. Then find out, estimate the gestational age and assess the contraction, its frequency, its duration, its intensity, whether you are feeling per abdominally or patient is also feeling the pain is also very important. And review the fetal heart rate tracing as well. Speculum examination, yes, very important. Very gently pass in and see the presence and amount of uterine bleeding, or is there any leaking, any signs of placental abruption. Fetal membranous status, is the cervix dilated, are the membranes protruding in it, or the cervix is closed, whether there is a cervicovaginal fluid, if necessary. Now, few institutes have started doing it, though we don't have these facilities. And I feel that we should have that. That is fetal fibronectin testing. It definitely will not help me to prevent, but predict, and maybe I can take a risk before patient goes in established preterm labor. So how do we go for that? I'll tell you shortly. Digital cervical dilatation. Remember one thing. If the cervix is more than 3 centimeters dilated, and if there are uterine contractions which are settled between 20 to 37 weeks, it supports the diagnosis of preterm labor, and inhibition of this acute preterm labor is less likely to be successful. The cervix is already 4 centimeters dilated. Patient got contraction. She is in an active phase of labor. Less likely you will be able to prevent, though if it is too premature to give a steroid you wish to work, you may. Less likely you will succeed. When assessing the dilatation and effacement in second trimester, it is important to distinguish between patients whose membranes have been prolapsed through dilated and effaced cervix, telling us that it is a cervical insufficiency, and those who are in active labor, and that's why there is a protrusion. Transvaginal ultrasound assessment of the cervix can help to distinguish between the two entities. Transvaginal sonography, short cervix, even per abdominally you can do that if expert comes into the picture. Less than 25 centimeters before 34 weeks is predictive that there can be increased risk. obstetric ultrasound examination for fetal, paternal, and placental and maternal anatomic abnormalities, confirmation of fetal presentation, assessment of amniotic fluid, fetal weight, all should be done together. And there should be a triage. Cervical length less than 1.9 centimeter, very high risk. Mainly chorioamnionitis will set in. Between 2 to 2.9, they are at increased risk, and I'll be careful and I start working with them. And more than 3 centimeter cervical length, you should be less worried about it. Now, apart from a perspeculum examination and other findings, and sonographic findings, what are the laboratory? One, high vaginal swab for culture. Second, urine culture. And third, I'm talking to you about the fetal fibronectin. In pregnancies less than 34 weeks with intact membrane, cervical dilatation less than 3 centimeter, length is between 2 to 3 centimeter. And if you find that, it may be helpful because you can predict and you can prevent. Testing for sexually transmitted infection also is important. Now, we all know that up to 20 weeks of gestation, it is natural to have a fetal fibronectin in a vaginal swab. But it is after, if you find the quantity which should be there is less than 20 milligram. If I'm coming to it, fibrinol, it is an extracellular matrix protein present at the deciduous chorionic interface. And disruption of this interface due to subclinical infection, inflammation, abruption, any contraction, there will be a release of it into the cervicovaginal secretion, which is the basis of a marker for productin. Measurement of it, qualitative as well as quantitative, both is important to distinguish the preterm and false labor pain. Now, a positive test refers when the concentration is more than 50 nanogram in a cervicovaginal fluid between 22 to 34 weeks. Below 22 weeks, we all know when the development is happening, you may get that. But value has to be above 50, between 22 to 34 weeks. If I find it, and if the cervix is intact, less than 3 centimeter, no gross vaginal bleeding, you can correlate that this patient can go in an increase. So those patients who have a high risk factors of prediction, polyhydramnios, you just do this. If you're worried about that patient, multiple gestation, you can think about doing it. Previous history of preterm, you can think about a combination of quantitative testing and cervical length. Both, if you take together, it will be fantastic. It will increase your predictive value. This is in 2016 publication where they have said that it is not associated with the prevention of preterm labor. So you find it, it has a prediction value, but doesn't mean you can prevent it, right? This is a very interesting study in 2023. This is a prospective double-blind cohort study using quantitative fetal fibronectin testing in a symptomatic patient for the prediction of spontaneous preterm labor, whether this patient will go. Quantitative has predictive value for spontaneous. This concentration could help the clinician to rule out preterm birth and avoid unnecessary intervention and hospitalization. So if patient says, I have a contractions, I have a menstrual cramps, I do have even the history. And when we saw only 13% of will go, what you can do is take a patient on a perspeculum examination, take a swab, put it for 10 seconds, collect it and send it for a quantitative. If it comes absent or a very low value, it means this is a false labor pain and you may not have to do anything. You can save a lot of stress. Diagnosis of a preterm labor, uterine contraction more than 6 in 60 minutes, plus cervical dilatation more than 3 centimeter, length less than 2 centimeter, or cervical length between 2 to 3 centimeter on trabeus and positive fetal fibronectin. So even if it is 2.8 centimeter, but positive fetal fibronectin, I will still consider. So how to identify who is at risk? Those I told you already, the risk factors. Then fetal fibronectin study, the quantitative, the length of the cervix, and then the symptoms of preterm labor. If I get to see all those 4 parameters, I'll definitely help. This is little crowded slide, but it's important. That's why I put it. Patient with preterm uterine contraction, intact member, reassure maternal and fetal status, no placenta previa or abruption. And if she's less than 34 weeks of pregnancy, cervix more than 4 centimeter, 3 centimeter dilated, preterm labor is likely to happen. You can try tocolytic antibiotic for a streptococci, magnesium sulfate if it is less than 32 weeks, and the steroids. But if the cervix is less than 3 centimeter, obtain the specimen for fetal fibronectin testing, hold until the results of ultrasound measurement of a cervical length are available. And if transvaginal cervical length is less than 2 centimeter, and if then you think about giving this patient, but probably it will undergo the preterm labor. Now, cervical length between 2 to 3 centimeter, perform fetal fibronectin test. If it is positive, it means patient will go. If it is negative, unlikely to be a preterm labor, observe the patient maybe for 12 hours, 24 hours. And if patient don't have any progressive dilatation, contraction, just send the patient back home and call for a follow-up, maybe weekly or 2 weekly, depending upon gestational age and her findings. Cervical length on transvaginal, more than 3 centimeter. Preterm labor, unlikely to happen. Observe just for a few hours. And then, so only when it is 2 to 3 centimeter, probably fetal fibronectin may help us in a situation whether she is going to go or she is not going to go. Now, in gestational age, more than 34 weeks, ideally no tocolysis or antenatal steroids, admit for delivery. If labor progresses, discharge home if contraction ceases. Though I know few will disagree with no steroids. Initial treatment of preterm less than 34 weeks. What we do? Antenatal steroids, a course of betamethasone or dexamethasone to reduce the neonatal morbidity and mortality. Single rescue course of a steroid is indicated in pregnancies less than 34 weeks that are high risk for preterm within next 7 days and in which the prior course was administered more than 40 days. So probably multiple pregnancy at 31 weeks, 32 weeks, I've given her a steroid. She did not go in labor. And at 34 weeks, maybe at the margin she came in, I may think of giving a single rescue course. Tocolytics only for 48 hours to delay the birth so that steroids can be given. Antibiotic prophylaxis for a streptococcal infection and neuroprotection. Antibiotic therapy has no role in treatment of acute preterm labor. It's okay. If she is in acute preterm labor and you are finding that it is because of infection, you will start the antibiotic. But if it is because of the over-distended uterus and all, this antibiotic, when you are knowing that it is not the infection or chorioamnionitis, no role. Progesterone supplementation also has no role in acute preterm. Why it is circulating levels of endogenous progesterone in third trimester are already very high. And they are sufficient to saturate the progesterone receptors and do not increase with the exogenous progesterone administration. So it is unclear why exogenous supplementation should be given. But you can think about that there may be an idiopathic or stress-associated preterm labor which has increase in a reproductive tract nuclear progesterone metabolizing enzymes. Therefore, increasing local progesterone level should have no or minimal effects. And then it should not be given. One theory to explain the possible efficacy in some clinical scenario is that exogenous vaginal progesterone may directly alter the vaginal microbiome or alter the inflammatory response to aberrant microbial states by its effect on a local glucocorticoid receptors. That may be the reason why vaginal progesterone some people think of giving. Otherwise, we saw there is an increase in a progesterone and there is no role. Steroids, either betamethasone or dexamethasone, both are acceptable, though betamethasone is preferred because it shows increased reduction in intraventricular hemorrhage. Not prefer. Okay. ACOG states administration of steroid is recommended. Now, because I'm telling you here, because I'm talking about preterm labor, I'm stopping the gestational age as 36 plus 6. I'm not talking between 37 to 39 weeks steroid role, which now we all know that RCOG guideline says up to 39 weeks. But because this is a preterm guideline, they have taken up to 36 plus 6. So administration is recommended between 34 to 36 plus 6 weeks. It should not be administered with the infection. Tocolysis should not be used to delay the delivery in patients with the symptoms of preterm labor to allow the administration of steroid. Medically or obstetrically indicated preterm birth should not be postponed for a steroid. But those which are not medically indicated or obstetrically indicated, there is no infection, then I can think about. If it is obviously abruptio or something, we will not be talking about. Patient going in a contraction because of the bleeding, we may not be thinking about. Okay. And there is no role in giving repeated doses. We all need to know that. NICE guideline on preterm labor and birth recommends considering the steroid for these patients between 34 to 36. RCOG do recommend up to 34 plus 6 of gestation patient in whom high risk for a preterm within 7 days is anticipated. WHO and FIGO have cautioned against universal adoption of steroids for a pregnancy or preterm between 34 to 36 because it is unclear whether short-term benefits, that is reduction in this thing, clearly overweigh the risk. Neonatal hypoglycemia, long-term neurodevelopmental outcome, and the metabolic risk. So use of repeat courses in patients who do not deliver, obviously, you should not be repeating. It is also suggested that doctors who elect to give a course of a booster therapy use 1 rather than 2 doses. Maternal side effects of steroids: transient hyperglycemia, transient leukocytosis, possibly transient uterine irritability, decrease in the fetal movement as well. Fetal heart rate and biophysical parameters get affected. Transient improvement in the umbilical artery and diastolic flow. This is very important. Tocolytic, which tocolytics, if at all I have to use? What can I use? What does this 2009 meta-analysis? It spoke about prostaglandin inhibitors being the superior over the other. All current tocolytic agents were superior with no treatment at delaying a delivery for both 48 hours and 7 days. Prostaglandin inhibitors were superior to other and may be considered as a first line before 32 weeks of gestation or to delay the delivery. And the most common prostaglandin inhibitor they were talking that time was an endomethacin, with the dose of 50 to 100 milligram loading dose, followed by 25 milligram orally every 4 to 6 hours. We all know the side effects of endomethacin, not only on maternal, but the fetal, constriction of the ductus arteriosus, oligohydramnios, more than anything, necrotizing enterocolitis, patent ductus arteriosus, periventricular leukomalacia, intraventricular hemorrhage, and that's why even in polyhydramnios patient, it's a one side effect which is beneficial for those patients causing oligohydramnios, but still endomethacin is not evidence-based medicine to give in those patients. Calcium channel blockers, nifedipines, more widely used nifedipine. Its action obviously is calcium channel blockers. They directly block the influx of calcium ion through the cell membrane. The resulting decrease in intracellular free calcium leads to myometrial relaxation. The doses, it can be loaded first with 20 to 30 milligram initial loading dose, followed by 10 to 20 milligram over 3 to 8 hours, up to 48 hours with maximum dose of 180 milligram. Obviously, you will be keeping a close watch on a cardiorespiratory system of the patient. We should be explaining with the hypotension, palpitation, flushing, vasodilatory effect of it. Of course, it's contraindication to patients who are hypersensitive, who have low BP, or who has preload dependent cardiac lesions. The concomitant use of calcium channel blocker and magnesium sulfate could act synergistically to suppress the muscular contractility, and it can result in respiratory depression or a hypotension. So be very, very careful if you want to give magnesium sulfate. At the same time, if you land up in a delivery of this patient, always remember this patient can go in a atonic PPH. So friends, be very careful when you are giving. Goal of a tocolytic should be delay of the delivery by at least 48 hours so that your steroids can be administered, provide the time for a safe maternal transport, or prolong the pregnancy when safe to do so, no obstetric complication or a maternal complication, when an underlying self-limited condition is inducing the labor, such as pyelonephritis, any abdominal surgery, but unlikely to cause recurrent preterm labor. So this is very important. If you have a non-recurrent, so you can safely control it, then probably you will be able to continue that pregnancy. What is the ACOG opinion? Interventions to reduce the likelihood of delivery should be reserved for women with preterm labor at a gestational age at which a delay in delivery will provide benefit to the newborn. Because tocolytic therapy is generally effective up to 48 hours only when women with fetuses that would benefit from a 48-hour delay in delivery should receive the tocolytic. This is very clear guidelines. The minimum gestational age at which inhibition of a preterm labor is reasonable is controversial, and it largely based on an expert opinion. Also, the availability of the tertiary center in your own place or the nearby. Tocolysis is usually not given before 22 weeks of pregnancy. There is more consensus about the upper gestational age limit for a treatment of preterm labor. In less than 28 weeks or 26 weeks, it is less individualized treatment protocol, or talking to the couple, taking them into the confidence, sitting with them, explaining pros and cons of extended neonatal ICU, not only the expenses, but the long-term effect on the neonate of this preterm baby also has to be explained. According to ACOG, 34 weeks of gestation defines the threshold at which perinatal morbidity and mortality are sufficiently low that the potential maternal and fetal complication and cost is associated with inhibition of preterm labor and short-term delay are not justified. So above 34 weeks, please allow it and don't give tocolytics. That is very good. Now, what are the contraindications for tocolytics? Of course, IUD, lethal fetal abnormality, non-assuring fetal status. You are in dilemma. The Doppler studies, forget biophysical profile, CTG. You are not much happy with this. We all have to understand that sometimes it is the baby who gives the signal when baby is not comfortable in utero. And that's why it's very important. You should not be preventing. You don't want to land up in an IUD. Pre-eclampsia with severe features or eclampsia, maternal hemorrhage or hemodynamic instability, intraamniotic infection, chorioamnionitis, where baby is more safe in outside than inside, preterm, pre-labor rupture of membrane, and medical contraindication for any tocolytic drugs. Oxytocin receptor antagonist. I think 2-3 years ago, it was a huge news which came in India, and atosiban came rocking. But the cost of it is so exuberant that its availability or its use by majority of the people is restricted. Also, Cochrane has said that it did not demonstrate superiority of atosiban. But let me tell you, friends, my experience, especially before 34 weeks of pregnancy, I have given atosiban to those who could afford to buy, in spite of accepting the fact that it may not prevent, and your 35 to 40,000 rupees will go in a waste. Those who gave me the permission to purchase and use it, I have found it absolutely fantastic. I'm not here supported by atosiban group, but I found that if especially the cervix is less than 3 centimeter dilated, you catch up. Atosiban, in 24 hours, the action beautifully it comes, it becomes quiescent. And after 48 hours of its complete therapy you give, patient has continued till term without any use of tocolytic or any other problem, provided yours should be the idiopathic and maternal-fetal condition allows you to use it. The finding of increase, this is very important. What Cochrane has said that they have found increase in infant death and more births before completion of 28 weeks in one placebo-controlled study. It warrants the caution. Neuroprotective effect, every one of you know. Before 32 weeks, we use it. How it helps? It stabilizes the cerebral circulation, prevention of excitatory injuries, protection against the oxidative injuries, and protection against the inflammatory injuries. Although maternal administration of Maxelf is not associated with decreased risk of fetal brain injuries that are believed to cause cerebral palsy, it has been associated with reduction in cerebellar hemorrhage in preterm. That's very important. Limit therapy for neuroprotection in only less than 32 weeks. This is the dose we give, 4 gram IV loading dose over 20 minutes followed by 1 gram per hour infusion. It discontinued at birth, and I told you, please consider atonic PPH in your mind when you are giving this. Contraindication, myasthenia gravis, myocardial compromise, and impaired renal function. Rationale for a progesterone supplementation. The rationale for progesterone supplementation is that endogenous progesterone contributes to pregnancy maintenance in several ways. Corpus luteum progesterone production, we all know in first trimester. We all know that placental progesterone production maintains the quiescent uterus. It also helps in immunomodulation. What is the recent article, meta-analysis in American Journal in 2019, they say is oral progesterone appears to be effective for the prevention of recurrent preterm birth and a reduction in perinatal mortality and morbidity in asymptomatic singleton gestation with the history of previous preterm birth compared with placebo. And there were also increased adverse effects with oral progesterone compared to placebo, although none were serious. So oral progesterone probably is coming up very much in the market also. Prophylactic vaginal progesterone and prophylactic cerclage. Consider progesterone for women who have either history of spontaneous preterm birth in before or result in a transvaginal sonography where the pregnancy is already gone beyond 20 weeks. You can't put the cervical stitch, and the cervix is going less than 2.5 centimeter, or the cervix was 3 centimeter, 3.5 centimeter, 3 centimeter. Now it has become 2.5 centimeter, progressive decrease in the cervical length. When using a vaginal progesterone, start treatment between 16 to 24 weeks and continue till 34 weeks. At 34 weeks, you should stop. Now, these are the guidelines which got updated at 2020. What I also do when I'm suspecting the small cervix, apart from giving just the progesterone, I do these patients vaginal swab cultures very regularly at 4 to 6 weeks interview, because short cervix, chorioamnionitis is the only thing you are worried. So you take a complete care, and I also explain the patient about the local hygiene to be maintained by her to avoid even Enterococcus fecalis infections. Does the vaginal progesterone prevent recurrent preterm with a singleton gestation with the history of a spontaneous preterm? Why I have taken this? Because this is little more recent, 2022 meta-analysis. There is no convincing evidence supporting the use of progesterone in recurrent preterm birth or to improve the perinatal outcome in singleton. Nevertheless, since there is nothing more we can do in patients who have started, probably she may be priming and decreasing cervical length, at least we think about avoiding vaginal infections. If she has any other associated risk factors, we may think of giving a progesterone because we have no other choice than to work. At the most, it may not work, but if it works, it's wonderful. So because you don't know the publication, how much they are biased, and then the meta-analysis comes, how much they are biased. So sometimes you might have to use because there's nothing else you have in hand. Management of pregnancy after resolution of an episode. Now, she came in an acute idiopathic. You could manage to prevent. There was no fetal indication or any other obstetric indication. And the pregnancy is continuing beautifully. What shall I do? Shall I keep on giving her antibiotics? Shall I keep her on tocolysis? What shall I give her steroids again? What does the evidence say? For pregnant people with a singleton pregnancy with short cervix on ultrasonography, vaginal progesterone supplementation may be considered. Multiple gestation, treating twin pregnancy with a short cervix with vaginal progesterone may be beneficial. Though if you detect it before 16 to 18 weeks, you can think about cerclage. Maintenance, this is important. Maintenance tocolysis, antibiotic prophylaxis, use of cervical progesterone pessary, fibronectin testing do not improve the outcome. The another evidence says. So there are two schools of thoughts over use of a progesterone, and I feel everyone should take their own individual decision. But continuation of antibiotics and all is not indicated. I definitely continue it till 34 weeks if I have started. Adverse patient that may resume most activities of daily. Now, patient next thing we should ask is, I'm now 30 weeks. I came in acute labor. You prevented it. I am going home. I took a rest of 1 week, whatever it is. Now, can I resume my activities? Can I start walking? Can I do my work? Or am I supposed to be bedridden? You don't need to be bedridden. There is a lack of evidence to suggest bed rest, but definitely avoid heavy weightlifting. Patient with at high risk for preterm birth, they can go for a walk if it is a less stressful. If it is more than 40 hours per week, they have night shift, prolonged standing, they may avoid it. Consider avoiding sexual activities also. It is unlikely that car travel, train travel, or air travel will increase the risk of preterm, and don't make patient scared of anything. Overview of intervention for this. So now, how do I prevent the risk? I know this patient may go. If low dose aspirin, for example, ART conceived, PCOS patient, preconceptionally obese patient, I may think that this patient has a high risk of going in a PIH. I may think of giving them low dose aspirin. Provide counseling and intervention to reduce tobacco and substance use. Also smoking. Identify individuals with abnormal BMI and help them. Provide counseling regarding optimal pregnancy spacing also, and avoid unplanned pregnancy. Reduce the iatrogenic multiple fetal gestation. Those who are ART consultant, they should think about this. Consider the impact of cervical or uterine surgery on future pregnancies. Sometimes we might have done a complete septum. You have to think that if you have taken out the cervical portion of septum also, probably this patient will land up definitely in incompetent us. Monitor the short cervix and treat affected patients with vaginal progesterone or a cerclage, depending upon at what gestation you found. Address the maternal infection risk. Routinely perform first trimester urine culture, treat asymptomatic bacteriuria, surgically correct congenital uterine anomaly when appropriate. You should be thinking about maternal infection, and obviously I spoke. So friends, advances in science is always for the betterment of human being. We are detecting, sonography is helping us to detect the decreasing cervical length, and transvaginal sonography is showing me 2 centimeter. I definitely will become cautious and I will start working on it. In my practice, before 34 weeks, definitely I try to avoid going then by giving a short-term tocolysis. And if I can prevent it, fantastic. And if I could not prevent, I give steroids and then I ensure that my neonatologist is available and then I take a delivery. Before 26 weeks of pregnancy, I always sit with the relatives and explain them that she may be going in a threatened preterm. I'm trying and avoiding, but if she delivered, these are the pros and cons of these babies. Friends, those who are from India, I humbly request you to support me for my Foxy presidential candidate. The elections are going to be electronic. From 1st August to 10th August, the digital line, individual links will be open. You cannot share the links with each other. Ensure by going on a Foxy's website, you all know your membership number, and also ensure that your email address and mobile number is given correctly. Thank you so much for your patient hearing. Thank you. Thank you, Raja. Precisely in 45 minutes, we finished.
Definitely, ma'am, definitely.
So do you have any questions?
Ma'am, let me check once. No, ma'am, there are no questions. I guess you made everything very, very clear to everyone. And
you also learn na preterm labor?
Yeah, ma'am, exactly. I was listening patiently, though there were a lot of terminologies which I didn't get, but then also it was wonderful listening to you, ma'am.
Thank you, dear. Thank you.
Thank
Bye.
you.
So
Bye-bye.
we will meet next month.
Sure.
Second Tuesday of the next month.
Okay, ma'am.
Which comes, we are next month in what, June?
Yeah, ma'am. In June, second Tuesday on 6th.
No, second Monday, sorry, 12th.
12th
next.
Yeah, on 12th of June.
Yeah.
Okay.
Thank you, dear. Thank you.
Thank you so much, ma'am.